Hi everyone, and welcome to another training session with Corsmed. Today we're going to do the routine brain MRI, one of the most common scans in the entire world. We're going to do this step by step and make sure you get every step and every image with high quality. I'm going to swap over to the Corsmed MRI simulator, so let's get started. Here is the Corsmed MRI simulator, which is where I will show how to run the protocol. In MRI, we always face a trade-off between three key metrics: scan time, resolution, and signal-to-noise ratio. If we improve one of these metrics, it reduces the performance of the others. So how should we decide what to prioritize when it comes to routine brain MRIs? Brain MRIs is one of the most highly requested of all protocols, so a short scan time is crucial. The brain is also a complex organ where most pathologies are identified by signal differences rather than by fine structural details. Therefore, you may want to slightly prioritize scan time, followed by SNR, and lastly resolution. Prioritizing scan time ensures you can accommodate more patients and reduce the risk of motion artifacts. Maintaining good SNR is typically the second priority, since many brain pathologies, such as multiple sclerosis, strokes, and tumors, are best detected based on their contrast against surrounding tissue, rather than on minute anatomical details that higher resolution provides. However, this is not a strict rule. The right balance always depends on the needs of your patient and clinic. If you're looking for small lesions or subtle abnormalities, for example, you may need to increase resolution and SNR slightly to ensure optimal image quality. Now, what health conditions can we diagnose with the routine brain protocol? Some of the most common conditions are tumors, metastases, and subacute hemorrhage. These can be detected with a T1 sequence, which shows clear contrast between gray and white matter and forms the baseline for post-contrast scan. Other common conditions are hydrocephalus, cyst, and edema. These show up well on a T2 sequence, which highlights fluid-related abnormalities by making fluids appear bright. We also have multiple sclerosis, small vessel disease, and chronic ischemia. These can be clearly seen on a T2 FLAIR sequence, which suppresses cerebrospinal fluid to enhance white matter lesions and chronic ischemia near the ventricles in the brain. Finally, we have acute stroke and cytotoxic edema. These are best seen with a diffusion-weighted image sequence, which detects ischemic changes mere minutes after they occur, which makes it critical for rapid stroke diagnosis. As you can see, there are many neurological conditions that may inflict a patient, and brain protocols are also used for psychiatric evaluations, such as depression and schizophrenia, and for neurodevelopmental conditions like autism. This is why the brain protocol is so popular and why it's especially important to master it. Now, let's get started with our protocol. We will assume that the patient is already positioned in our scanner following all the safety regulations. The first step is to check the hardware settings of our MRI system. We are working with a standard MRI hardware specification. This includes a 1.5 Tesla magnetic field strength, a gradient performance of 45 milliteslas per meter, and an optimal coil selection. For this scan, we'll be using a coil positioned near the brain, which ensures we get full coverage and an excellent signal quality. In clinical practice, this is the head birdcage coil or the gantry birdcage coil. But for today, we'll use our optimal coil because it provides the best signal in the simulator. Now, let's start setting up the protocol. In the routine brain MRI protocol, we want to get a good visualization of the whole brain. To achieve this, I will adjust the slices shown in the viewport slightly to make sure we have a good central slice in all three views. You can see the image number here in the top left corner of each viewport. Let us scroll to a slice number in the middle, like 16 for all the three viewports. We are then ready to add the pulse sequences for this study. We can go to our Standard Protocols tab and look for the routine brain folder. The typical routine brain protocol will always start from an axial scan, which is acquired with multiple types of contrast: a T1, a T2, and also a special FLAIR sequence to null the fluids. A standard brain protocol also includes a sagittal and a coronal view, which are often acquired in T1 contrast. And finally, an axial diffusion-weighted image sequence. However, this selection is only a general recommendation. Your clinic may have its own requirements, and if so, you should follow those specifications. Now, we will add the sequences and open the first one to start planning it. We begin with the axial scout. We can right-click on the image, select Copy Image Position, and we will see our slice across the anatomy in the sagittal view. The area we are interested in is the corpus callosum, which you can see here. And we are positioning our slice in the anterior part and the posterior part of this area. We will align the slice parallel to the anterior commissure and posterior commissure line. This is also called the ACPC line. Alternatively, we can align it using the genu here at the front of the corpus callosum and the splenium here at the back. So we will position the slice along this imaginary line in the sagittal localizer. On the coronal localizer, we reference the mid-sagittal line. This line runs from the sagittal sinus at the top through the third ventricle and down to the base of the skull. We will position the slice package perpendicular to this line. Now, in the axial viewport, we will adjust the field of view. We can reduce the field of view dimensions or switch to a rectangular field of view if needed. We will also increase the package size in the phase view to prevent wraparound artifacts, particularly from the nose. Notice that we currently display only one slice. This is because we haven't decided on our coverage yet. Our coverage can extend to about 20 slices. Once set, we can drag our package all the way down so that it covers from the vertex to the base of the skull in both the sagittal and coronal view. If necessary, we center the package in the middle of the axial view for proper alignment. We can play with the slice thickness depending on our indication and adjust our slice gap. So we may want to reduce this by 1 and add another couple of slices. Since this is a T2 acquisition, we need to acquire it with a long TE like 120 and a long TR like 5000. In the blue box down here, we can see key stats about the sequence, such as its scan time and signal-to-noise ratio. We currently have an optimal signal-to-noise ratio, but if we want to speed up the scan time, we can also think about reducing the number of averages. This will introduce more noise into the images. So for an optimal acquisition, we can keep our averages up to 2. Then, in our special tab, we can influence our contrast by adjusting the turbo factor. Since this is a T2 weighted sequence, we will use a higher turbo factor. This emphasizes signals from tissues with longer T2 relaxation times, which enhances the T2 contrast. We can then click on Save and run this first sequence. It's a good practice to copy the slice position from this sequence to the remaining 2 axial sequences. This ensures we get the exact same slice positioning, which lets us compare the resulting images more easily. So now that I have selected the T2 FLAIR sequence, I will right-click on the axial T2 and then click on Copy. As you can see, this is reflected in our viewport. Next, in the Sequence tab, we will check that the parameters for this T2 acquisition are correctly set. These are typically pre-configured for your practice as part of the standardization process. Once an optimal protocol is established, it is often saved in the standard protocol list on your scanner. Now, let's look at adjustments specific to this acquisition. For instance, we can add fat suppression if needed. And because this is an inversion recovery sequence, we must also consider the inversion time. We are using a longer inversion time of 2500 milliseconds. This value is designed to suppress or nullify the signal from a specific tissue. In this case, the cerebrospinal fluid. Cerebrospinal fluid has a long T1 relaxation time, meaning it takes a long time for its protons to recover their longitudinal magnetization after the inversion pulse. By setting the TI to 2500 milliseconds, the MRI sequence targets a point when the CSF magnetization crosses 0. At this point, the CSF appears dark or suppressed in the image. This lets us see the surrounding tissues, such as gray matter, white matter, or abnormalities, more clearly. On most scanners, the inversion time for cerebrospinal fluid typically ranges between 1800 and 2500 milliseconds. This value is typically already determined at your practice. To find the appropriate value for your scanner and magnetic field strength, a pilot study would have been conducted with several healthy volunteers. This ensures the value is preset and known for your scanner. We can then click on Save and run this pulse sequence. In the meantime, we can check our output image. And as you can see here, our image is correctly displaying the anatomy. We can scroll through the slices, and on each side of the brain, we can see that the structures appear and disappear together. In a healthy brain, the structures are usually symmetrical. That symmetry helps you know if the scan is good. If the right and left sides don't match, like if the ventricles don't show up at the same time, you might need to run the scan again to fix it. Here, we have the resulting image for our FLAIR sequence. As you can see, the level of noise is much higher compared to the standard T2. This is because we acquired the image using just one average. To improve this, we can create a new T2 FLAIR sequence by cloning our current one. We will then go into the sequence settings and select a higher average. However, increasing the average from 1 to 2 will double the acquisition time. So you need to be mindful of which metric is more important in your specific situation. We can then click on Save and run this pulse sequence. Next, we double-click on the T1 sequence to open it. As before, we will copy the slice positioning from the previous axial sequence. This time, I'll go into the sequence settings and increase the averages from 1 to 2. Now, pay close attention to the TE and TR values. For this T1 scan, you'll notice that the TE is in the low 10s and the TR is in the hundreds. This means we are acquiring a T1 weighted scan. Since we want to compare this T1 with the T2 and FLAIR sequences, we need to acquire them in the exact same geographical and geometrical positions. That is why we copied the slice position. I'll now go ahead and save and run this sequence as well. In the meantime, my FLAIR sequence with less noise is ready. So I will upload it in the right viewport. I will also drag and drop the image with more noise into the middle viewport so we can compare them. As you can see here, the noise has decreased significantly in the improved image. Let's focus on this structure where fat suppression and cerebrospinal fluid suppression occurred. We can see the two distinct layers. If you're new to MRI, it might be hard to spot them. In the noisier image, these layers are not visible at all. By improving the signal, we have enhanced the visibility of these structures. Now, let's move on to acquiring a sagittal scan. First, we'll re-upload our localizers. Sagittal, coronal, and the most recent axial image, which reflects the true position of the patient. We should always plan our slices using the latest image we have acquired. In this case, I'll use the latest axial as my localizer for the sagittal scan. I'll go to the sagittal scout, copy the image position, and then move to the coronal view. Here, I'll position the slice on the mid-sagittal line, so our slice is exactly on top of it. We want to be as parallel as possible to the line running from the sagittal sinus, through the third ventricle, and down to the base of the skull. In the axial view, we also want the scan to be parallel to the anatomical reference. Once we've aligned it correctly, we can adjust the coverage. We'll keep most settings as they are, but we will set the fold-over direction to anterior-posterior, and we will slightly reduce our field of view coverage up and down, as we don't need it to be that big. Next, we'll cover the brain from side to side. I'll set the coverage to roughly 18 slices, and since I'll decrease the slice gap, I will need to increase the number of slices again to about 20 or 21 slices to make sure we cover the entire brain. For the slice thickness, we'll leave it as it is. Now, I will reuse the same two averages and similar TE and TR values as before. You can either match those values or use the standard settings suggested at your practice. Once everything is set, we will click on Save and run this pulse sequence. Finally, we need to cover the coronal sequence. To do this, we will copy the image position from the coronal localizer. For this view, we want the scan to be perpendicular to the mid-sagittal line. So I'll carefully twist the line like this. So the dashed line is perpendicular to the mid-sagittal one. In the sagittal image, which will load in just a moment here, I'll scroll to the mid-slice. And in my axial view, I'm going to position the slice here so that it gives me that nice blue line. This is my reference for the ACPC imaginary line that I've spoken about before. We will then orient this yellow package exactly perpendicular to this blue line, more or less like this. Then again, we'll increase the number of slices and decrease the slice gap. For the fold-over direction, I will select right-left. This lets us keep the field of view small so that we avoid wraparound artifacts while maintaining good coverage. We'll make sure to cover the entire brain, from the occipital to the temporal lobe. Next, we'll check that we have a short echo time and short repetition time to ensure we get the T1 contrast we need. I will set the TR to 575 milliseconds. Once everything is set, we'll click on Save and run this pulse sequence. Finally, we will acquire the diffusion-weighted image, DWI. A diffusion-weighted image is highly useful for studying the vitality of the brain, particularly for detecting acute ischemic stroke. It is the gold standard for identifying cytotoxic edema, which occurs when energy failure leads to intracellular swelling and restricted water movement. As you can see here from the sequence description, it uses an axial view, so we'll copy the slice position from our axial FLAIR sequence. However, the diffusion-weighted sequence does use fewer slices than a standard axial scan, so we'll reduce the slice count. We also need to position our slice package to avoid the paranasal and mouth areas. These areas have a different density than the brain, which can cause susceptibility artifacts if they are included in our scan. We'll therefore shift the entire slice package slightly upward. Another thing you can do if patient anatomy causes issues is to rotate the field of view clockwise to improve the image. In the coronal view, the scan should always remain perpendicular to the mid-sagittal line. The diffusion-weighted image has a special value called the B value. which controls how sensitive the sequence is to the movement of water molecules. In healthy brain tissue, water flows naturally along and between cells. But in damaged areas, like a stroke or a tumor, water gets trapped because cells swell or tissue becomes denser. A high B value in DWI makes the sequence more sensitive for detecting restricted water motion. If we see a high DWI signal, it suggests that water diffusion is restricted in that area, which can indicate stroke, tumors, or infections. In stroke, cells swell due to lack of oxygen, trapping water and reducing its normal diffusion. If we see this, we must act immediately to prevent permanent damage. We will now save this sequence and proceed with scanning. If the system flags the minimum TE value as inappropriate, we can check what adjustments are possible. One option is to lower the bandwidth further to reduce the TE. Another option is to decrease the number of averages, since we don't need a high value here. We should also check the matrix, as a very high matrix isn't necessary for this type of acquisition. We can play around with some different values, but a value around 100 phase and 64 read should be sufficient. A diffusion-weighted image does not require as high resolution because its main goal is to detect restricted water diffusion rather than detailed anatomical structures. However, the resolution must still be high enough to avoid partial volume effects. Usually, a routine brain scan is acquired for B values of 0 and 1000. Some protocols may include an intermediate B value, like 500, for specialized assessments. But in this example, we will only acquire with 0 and 1000. Now we can apply the sequence. The system no longer flags an issue with the TE, so reducing the averages and significantly lowering the matrix was enough. Now that the scan is complete, we can open the viewer to review our images. We can double-click to bring up the FLAIR sequence. Here we first see the T2 image, as indicated by the bright signal in the fluid-filled structures. By hovering over this tool with the mouse, we can see the name of the structure in the top right corner. In a T2 sequence, fluids always appear bright, and since the brain is surrounded by cerebrospinal fluid, we see a strong outline of these liquid-filled spaces. Now, let's check our first FLAIR, which appears very noisy. We then have a second FLAIR with significantly less noise after doubling the averages. Since this is a T2 weighted image, but with FLAIR, we are nulling the signal from the cerebrospinal fluid. This makes the ventricles appear dark, while anything bright represents either tissues with different properties compared to water or possible pathologies. Now, let's check a T1 weighted image. Unlike T2, T1 images show higher brightness or hyperintensity in fat. Here, we see this effect in the fat layer surrounding the anatomy, just beneath the skin. Next, we have a sagittal T1 view, which displays the same type of hyperintensities. We can also have a look at our coronal T1 view. This view lets us compare both halves of the brain side by side. As we scroll through the images, we can again verify our scan quality by checking that the anatomy of the brain is symmetrical. This scan appears nicely symmetrical on both sides, which indicates not only a healthy brain, but also that we have a high-quality diagnostic scan. The anatomy appears in the middle of the field of view, with no wrapping artifacts. We can also see the structures of the brain anatomy clearly, thanks to the T1 contrast we set. Finally, let's examine the diffusion-weighted images. Here, we can check the B value to understand what we are visualizing. Scrolling to a middle slice, we see three types of images. First, we have the true diffusion image, which provides the actual diffusion information. Second, the ADC map, or apparent diffusion coefficient map. This map tells us where true diffusion changes occur in relation to the anatomy, which helps us understand the underlying tissue structure. Third, we have the susceptibility map. This map highlights variations in magnetic susceptibility caused by tissue composition or collections of iron. This map is especially useful for identifying brain hemorrhages, as blood appears dark in T2 star-weighted images due to susceptibility effects. That brings us to the end of our tutorial. To recap, here are the most important takeaways to remember. First, we generally prioritize scan time, then signal-to-noise ratio, and lastly resolution. Because the routine brain is one of the most commonly requested MRI protocols, we often need to optimize for scan time to ensure we can complete all requests in time. SNR also tends to have a slight priority over resolution, as most brain pathologies are better detected by their contrast against surrounding tissue, rather than by fine structural details. However, this is only a general recommendation and not a strict rule. Your priorities may shift if you need to visualize finer details in the brain or if short scan time is less urgent. Second, we mainly use fast or turbo spin sequences for this study. This type of sequence provides fast and high-quality images with excellent contrast and few artifacts. This makes them ideal for routine clinical diagnosis. They also let us create image contrasts in T2 and T1 weighting, as well as inversion recovery for fat suppression. This helps us assess the brain's structure, detect abnormalities, and identify common pathologies like tumors, strokes, and demyelination. Third, make sure to avoid the common artifacts that can arise from the brain region, which include motion, susceptibility, chemical shift, CSF flow, truncation, and wraparound artifacts. Some techniques we can use to avoid these artifacts are to shorten the scan time, use spin echo instead of gradient echo sequences, increase the bandwidth, use flow compensation gradients, increase the resolution, and activate fold-over suppression. Spin echo sequences are less sensitive to magnetic field inhomogeneities than gradient echo, which helps avoid susceptibility artifacts. And using flow compensation gradients, also called gradient moment nulling, modifies the MRI gradients to correct for the phase shift of the cerebrospinal fluid. If you cover all these 3 points, you will be able to perform excellent brain MRI protocols. Thanks for joining, and I will see you in our next session.